Hello, my name is Dr. Greg Thomson. I am the current chair of osteopathic principles and practice here at the beautiful Lincoln Memorial University DeBusk College of Osteopathic Medicine. Today we're going to be talking about ligamentous articular strain. It is a wonderful osteopathic technique that I typically will call OMM for the doc in a hurry. It's a great opportunity, I think, to talk about some things that will be good review, I hope, and hopefully not overtly boring, because it really plays to a review of things that are important in regards to why somatic dysfunction occurs and why what we do manipulatively seems to improve the general structural complex that we're trying to fix. So the muscle spindles, joint mechanoreceptors, and Golgi tendon bodies are those things that we will review and go over about physiologically. We will talk about the ligamentous articular technique as a treatment methodology, what the indications are, and then how to actually perform it. As a reminder, techniques can be characterized as two types: direct, if they take the body towards the restrictive barrier, where it doesn't want to go, and indirect, if they take the body away from the restrictive barrier or towards a position of ease. Motion within any articulatory mechanism of the body are under both voluntary and involuntary control. We will utilize involuntary control to assess why somatic dysfunction occurs, and for the kind of manipulation that we'll be doing with LAS, or ligamentous articular strain, we will recognize that we don't need the patient's cooperation. Type of motion that occurs in any given joint surface is determined by the shape of the joint surface, the position of the ligaments, and the forces of the muscles, especially during somatic dysfunction, that are acting upon those joints. Remember that ligaments don't stretch and contract as muscles do. Consequently, the tension in any ligament has very little variation within a joint that is non-dysfunctional. That tension distribution dramatically changes, that the ligamentous tension throughout a joint is spread out fairly evenly and is balanced, as I said, when there is no overt dysfunction. But when we have joint dysfunction occur, the ligamentous complex dramatically changes the way it rests. So we take a normal joint position, again within a normal range of motion, and the relationships between the joint's ligaments change. We know that. They bend, they twist, they turn. However, while the change in the tension of each ligament may dramatically shift or change, the overall tension in the whole joint remains about the same. It's evenly distributed, it's evenly spread out. Now, that doesn't mean that the tension in each ligament is exactly the same, but the overall tension remains the same. So we get some that'll slack, some that'll increase in tension, but when we have dysfunction, that dramatically changes. If the distribution of tension between the ligaments is altered and it persists, it does not come back into balance. So during somatic dysfunction, the proper distribution of tension with any given ligament will change according to the position of the strain of the joint, which is fine, but it does not come back to a neutral position. And thereby the shared tensions within the ligamentous articular mechanism of any given joint that has remained constant when in the neutral position or when in an undysfunction state will, in a dysfunctional state, not come back to a state of balance. So this reciprocal tension mechanism is altered and aberrant during dysfunction. So let's switch gears for just a second, talk a little bit about nociceptors. Nociceptive pain or input can disrupt the balance between these proprioceptive mechanisms and the higher levels of the CNS and dramatically change the interplay that occurs at the level of the spinal cord. These findings, coupled with studies that show increased sympathetic nervous system firing at the spinal level of the somatic dysfunction, which results in hypertonicity, may partially explain how somatic dysfunction is not only created, but also how it's maintained. Trauma can change the balance within the ligamentous articular mechanism. It can strain the joint, if inappropriately moved, in either scope or speed, within or beyond its physiological range of motion, so that that balance that we would call neutral is distorted. This is different from a ligamentous tissue strain or sprain, which commonly occurs when the tissue is taken beyond its anatomic range of motion and tissue injury is created. So how do we get to persistent somatic dysfunction after an injury? Well, I hate to say it, but we've got to go back to some basic physiology. If you look at the, we'll call this the elbow, since that seems to be what they're referencing. We have the flexor in the front, on the left side of the screen, the extensor in the back, and we have three sets of receptors that I want you to look at. From on the bottom left, we have the Golgi tendon organ, which is at the tendinous insertion. We have the joint receptor, or the mechanoreceptor, at the articular joint surface. And then just above it, we have the nerves coming into both the flexor and extensor muscles. That'll be consistent with the muscle spindle complex. Muscle stretch reflex is what we'll look at first, and stretching a muscle spindle fiber creates a volley of impulses in the sensory neuron, the afferent, called a 1A neuron. This afferent neuron has a sensory axon to the spinal cord, and it forms multiple kinds of synapses. Some of these branches of the 1A axons synapse directly with alpha motor neurons, so we get a direct feedback from 1A, which is a sensory, in this case we'll say the biceps, and an immediate response back through the alpha motor neuron back to the biceps. These will cause these impulses to come back to the same muscle that was irritated, to cause it to contract and maintain its tone, and contraction is needed. Whether it's through work force or being stretched, it will offer some resistance during that process. Now, I know that nobody likes to look at these anymore, but if we can just for a moment look at the two different types of sensors. We have both sensory and we have motor. We have type 1A and type 2 sensory in the upper right-hand corner. Type 1A sensory is the afferent fibers from that fusomotor complex, from the nuclear chain fibers and nuclear bag fibers. The type 1A sensories are the afferents that register to the muscle that it's being stretched. The type 2 is a very different kind of fiber. Type 2s, they are highly myelinated, in fact some of the most highly myelinated in the body, and give position, not necessarily rate of change. And so it's the position of whether or not I need to maintain tone to keep from falling over. It tells the body, how contracted I am and where I am in time and space. So it has a significant proprioceptive mechanism associated with it. On the top left, we have gamma motor neuron, which is the response to stretching the muscle back to the fusomotor complex. That gamma motor neuron is what increases or decreases the sensitivity of that spindle complex, and allows the body to overreact to a stimulus. And it resets that muscle. As I contract the muscle, the fusomotor complex resets itself so it can then be stretched, but it's also being activated to tell the body where it is in space and time. So proprioceptive as well. And then the alpha motor neuron is to the extrafusal muscle fibers, which allow the muscle to contract itself. On the bottom right, we see that the type 2 sensory fibers are typically associated with the Golgi tendon complex and are more associated with telling the body that you're stretching the tendon to the degree that may cause significant harm to both the muscle and or the bone. But in either case, it's the tendon that's being irritated, and so it's going to cause a slightly different response than the muscle fibers, than the spindle complex is. And then, of course, as we go on to the next slide, we'll see what exactly happens with a muscle stretch. As you stretch the muscle, it creates a neurologic response that ends up coming right back on itself. When I stretch the muscle, if I have you pull on my biceps, and as you do that, it stretches the muscle spindle complex. The body, feeling that resistance and that stretch, is going to increase alpha motor tone back to the biceps to resist from being overstretched too fast or to a degree that allows any type of muscle damage. Now, the interesting thing about muscle spindles is that they've shown that overstimulation of that complex increases afferent activity, but it results in a reflex contraction of the muscle it occupies and a reciprocal inhibition of the antagonist muscle via interneurons. Well, that shouldn't be too hard to remember, because as you pull on my biceps, if I'm actually going to allow my arm to lengthen, I'm going to have to allow my triceps to relax. So that inhibition to the antagonist muscle helps to allow normal motion. But it also occurs during somatic dysfunction. And if we remember that in just a few minutes, it may help to be able to explain to folks why, in fact, we want to fix somatic dysfunction. If we shorten the muscle complex, this leads to a decrease in that process, and we decrease the amount of tone to the agonist muscle and allow, again, the antagonist muscle to actually increase a bit in tone to counterbalance. Again, we don't want to accelerate too fast in either direction, and so tone typically is maintained in either direction. But during any kind of indirect technique, as we shorten a damaged muscle or a hypertonic muscle, we are going to see a slight increase in the antagonist tone to counterbalance. We also noticed that available data reveals that low threshold joint ligament receptors, or the mechanoreceptors, those typically only evoke a weak effect on the alpha motor neurons. However, they produce an incredible, powerful influence on the gamma motor neurons, which is what is telling the muscle where it is in time and place and whether or not there's too much or too little tone. They will cause that intrafusal muscle to contract, so they make the spindle more sensitive to stretch. They influence muscle tone because that sensitivity to stretch has increased, and therefore the resting muscle length has been influenced. As we irritate a muscle and tell it that it's under too much tone, and tone in this case is that I'm having a load placed across it, and so I'm stretched and I don't want to be stretched, I want to relax it. It's actually going to increase muscle tone a bit more to take that stretch off. Well, if I'm being irritated on a regular basis over a period amount of time, that's going to cause an inflammatory process because we want tone to be as minimal as possible, not maximal. So here's a slide that allows the gamma motor neurons, the attachments there, and as a reminder, the type 1As are off to our sensory afferents, which are letting the amount of stretch that's going on. The type 2s are letting us know where we are in time and space, and then the response to that is through the efferents back to those bag and chain fibers. So as we look at the effects of gamma muscle spindle system in the muscles around the knee, they're so potent that even stretches of the cruciate ligaments at relatively moderate loads, not noxious, just normal amount of movement, can induce major changes in response to the muscle spindle afferents. So tone is dramatically affected by the ligamentous complex and how much they're being stretched, whether they're being put under an aberrant non-neutral load, which isn't necessarily in the AP axis. It can be from a torsion axis. It can be from a twist. An easy example might be where the tibia sits under the knee in a slightly internally rotated position, putting a stretch on the cruciate and collateral complex, increasing the amount of tone so that a runner who has now got a non-neutral dysfunction in their joint surface is having an increased amount of tone that they have to account for, wearing and tearing, increased energy consumption, and more likely to cause injury and inflammatory changes, which may be construed as overt just knee pain for no particular reason on their mind. But it's all done at the sort of involuntary subconscious level of this system. So we'll throw in the joint mechanoreceptors. They're very sensitive at extremes of joint angle movement. Okay, that's a no-brainer. If you move it too far, it hurts. In the presence of inflammation, which we have just stated that increased tone on a joint that is not wearing in a neutral or a normal set of axes of motion, will cause wear and tear and inflammation. But also in the presence of increased fluid pressures. Now, for this discussion, I'm not so much suggesting that we're looking at the increased fluid pressures as to the cause of somatic dysfunction, but how to get rid of somatic dysfunction. So taking that idea, we'll recognize that stimulation of these articular mechanoreceptors can cause reflex inhibition of the muscle contraction to reduce further irritation of the joint. So in other words, I've got a muscle that's under a significant amount of tone. I cause the mechanoreceptor to fire, which decreases the amount of tone, which allows me to slide that joint back into place. Now, while it has a greater effect on the extensor muscles, it still can affect the flexor muscle groups as well, and we'll show you a good example of that in the lab coming up here in just a second. So, for the final receptor, we look at the Golgi tendons, and of course they're part of that proprioceptive system as well. The group 1B afferents, which let the which of the afferents from Golgi tendons make those polysynaptic connections, and those polysynaptic connections tend to cause a dramatic decrease in tone in the muscles that are surrounding the joint when these Golgi tendons are triggered. Now, in this case, that muscle tension is being, prior to actually fixing it, is increased in some dysfunction. You contract the muscle, it's going to be more irritative on these Golgi tendon organs because there's already too much tone in place, and so it's going to feel this increased tone, and it's going to start firing on the system. You pull too hard, too fast to safeguard the anatomic integrity of the joint. These produce a marked inhibitory feedback of the information from the muscle spindle, or in this case, the muscle stretch reflex complex. When that amplitude becomes too great or too fast, we then get this relief reflex. So to prevent muscle tearing, the muscle actually gives way to prevent yanking on the tendons at the bony junction or a tear in the muscle as you pull on them. We're going to use this relief reflex to our advantage. So as the Golgi tendon gets yanked on, you then get an inhibitory effect which causes the muscle to relax and thereby inhibiting this neuron. So if we use this to our advantage and we know that there's a muscle complex that has too much tone, and we know that we have a couple of things that will turn off that muscle tone, what happens when we utilize that for treatment? Which I think is what we just said right there. So we have the spastic muscle, it's stretched during OMT, which will be inhibited by the Golgi tendon organ, increases tone to the antagonist, but it decreases tone to the agonist, and that allows us to reset a joint that has been left out of position. So we'll go ahead and we'll take this joint, we'll look at it, and both receptors, we'll say both ligaments are under a normal amount of stress and strain. We then go ahead and move the joint in a position of use. In this case, let's just say we're bending our finger. One ligamentous complex, A, will be stretched. One ligamentous complex, or muscular complex, you can look at it from either direction, is then shortened. As we initiate the stretch in A, we shorten B. In this position, the joint is less stable. It's more susceptible to trauma. So in this case, we strain it further in the direction of stretching A. Well, A is going to give way. A is going to give way because of the Golgi tendon reflex. You're going to get a relief reflex, but it's going to increase the amount of tone in B. So this increased tone in B, when you return the joint back to its normal position, remains strained. The joint, whether it's a vertebra or a finger or a tibia, is now going to have a set of agonist-antagonist muscles, agonist-antagonist ligamentous complex, that has been left aberrantly positioned. And the body has a great deal of difficulty returning this back to normal. Lots of folks over time can have some act dysfunction rearrange itself and fix themselves, but those aren't the people that we have to fix. The people we have to fix are the ones who, for some reason, cannot get past this strain pattern. So this articular restriction has, now that it's out of position, increases the sensitivity of the mechanoreceptors, the gamma system within the muscles and the muscle spindles themselves, and it leaves the Golgi tendons on a sort of a hair trigger. We then begin to see, as this wear and tear continues, and we talked about the chemical and the hypoxic situation that can then occur, and we see that manifest itself in TART. We recognize that we have this normal range of motion that has been changed, and so that the range of motion you see on the bottom has this strain pattern that is now resting in an aberrant position. If we were to move to the left in the direction that the range of motion can't go, that would be direct. If we were to move the range of motion, again on the bottom there, in the direction to the right, in the direction it already is going, that would be indirect. But who wants to do indirect today? We're going to do direct. So ligamentous articular strain. We position the joint into the barrier. We place the patient opposite to the position of strain. In this case, if we're looking to the left at the picture, we're going to go ahead and move the the bone on the top to the right. So we will shorten A and stretch B. We're going to stretch it. We're going to stretch that aberrant hypertonic muscle ligamentous complex in the direction it doesn't want to go. So what are we going to do there? Well, we're going to flood afferents. We're going to stretch a muscle, so we're going to get the muscle spindle complex to say, to cry uncle. which, as we talked about earlier, is going to dramatically cause an inhibitory complex both at the mechanoreceptor, at the Golgi tendon, and hopefully take advantage, which will be typical for a relief reflex, and hopefully take advantage of something called habituation. In the case of the muscle spindle complex, as we shorten A and stretch B, that muscle spindle complex also, if left in the same position for an amount of time, will begin to recognize that this strain pattern that has been induced, in fact, is not getting worse, it's not accelerating, and it allows that fusomotor complex, the gamma afferent efferent, or the gamma efferent system, to recognize that it's more towards the position of neutral, and it will start to recognize that, habituate to it, and then diminish. So we get from all complexes this tendency to allow a normalization of the joint to occur. So this joint dysfunction is maldistributed. We're going to move it in the direction it doesn't want to go, and we're going to get rid of that compensated, unbalanced motion that has been persisting. This local friction, wear and tear, increased energy consumption, as I mentioned before, and inflammation creates a problem, and this distribution of forces is what causes, over time, a dramatic loss of the ability to compensate, not just locally, but also distally. The person who has an ankle that they're compensating for begins to use long levers and change, both by pain and lack of function, the motion of their knee, and then ultimately as their knee becomes compromised, their hip becomes compromised, and so forth and so on. So if we're going to use LAS, we're going to apply it in a direct way, as I mentioned, and it can be, as a reminder, this technique can be used in any joint that you care to utilize it in. We'll do a few during the lab, and hopefully it'll be something that many of you have not tried before, but after you try it once or twice, we'll find that it is very, very helpful. As always, we are going to diagnose by the use of TART. Remember, I want you to focus on range of motion. Other professions focus on symmetry. Not a big on symmetry. Symmetry gets you to the area. Pain gets you to the area. Tissue texture changes get you to the area. But range of motion is everything. If something is in a normal range of motion but asymmetric, there's nothing to treat. So this range of motion is really what we're going to be after. And I will show you a slightly different way to diagnose a range of motion. We'll then go ahead and use the XYZ axis. Flexion, extension, side bending, rotation can be applied to any joint surface. It's not just about limiting what you think may be only an AP or flexion extension sort of ability, but you're going to look at the joint in 3 dimensions. And remember that Fryette's law doesn't necessarily just apply to the spine. Fryette's third law will remind you that anytime you move a joint in any one direction, you compromise the other directions it has the ability to move in. And so taking that into account, our job is to find a barrier, and we're going to just gently but firmly take it further into the barrier. Now, as we do that in the x-axis, or we're then going to do it in the y-axis, and then we're going to do it in the z-axis. You're going to try and find all of the different ways that you can to take this to where the joint doesn't want to go. It can be a little uncomfortable, so you have to take care and probably watch your patient's face. Make sure that you're asking, are you tolerating this okay? Is this okay? But, that wince sign, when someone's eyes close shut and their mouth broadens in a firm grimace, should let you know that you're pushing probably a bit too hard. Now, the range of motion that you expect can be gleaned from the other joint on the other half of the body that is not compromised, and so you should be able to figure out how much of a range of motion you're at least after. As long as you don't have any tissue damage, then it should be something that would be obvious from beginning to end that you've actually improved range of motion. What you're going to do is you're going to engage the barrier, and then you're going to apply a slightly compressive force. Now, classically, you don't apply a compressive force, but if you think about a still technique, if you think about FPR, what I'm going to do is have you move a joint into its barrier so that you have ligamentous resistance, that you have muscular resistance, and then you're going to apply a gentle compressive force into that already immobile joint. As you engage that barrier and you add your compression, you're then going to maintain awareness of that until you get softening. Now, the softening, because you actually have three dimensions that you may be engaging, as one axis begins to soften, you're then going to be kind of mindful of the other axes of motion, and if one softens, you're going to change to the axes that don't give way. So you're going to chase the firmness. As it softens in one direction, engage another axis and see if you can find it resistant. Now, you're going to look for two endpoints. There's two possibilities, and depending on your experience, you can choose either or. Both of them are just as valuable. If you know how to feel the Traub-Herring-Mayer wave, which is the cranial rhythmic impulse, with flexion and extension, that will return as the joint releases, despite this compression. You will be able to feel a return of flexion and extension despite this compression. And you can do both, an obvious impression of softening of the joint or bone. Well, now, we know that the bone is clearly not becoming soft, but the sensations that you will feel in your hand is felt as though it actually were becoming soft, and the joint becomes more pliable and free. After you feel like a dramatic softening has occurred, not only in the directions that you've been pushing, but also a global sensation in both hands, as though the entire agonist-antagonist synergistic complex has released and softened, you then go ahead and recheck for motion in the expected planes. Why do we do this? Well, we have abnormal joint motion. So what are we looking for? Restoration of it. We're looking for all of our neuromuscular physiology to be restored. Any of the edema, any of the bogginess, any of the erythema. We're looking for an improvement in oxygenation of the area. So those tissue texture abnormalities will disappear. Decreased in edema. Softer, more symmetric. Restriction of motion is eliminated. And then tenderness is either gone or greatly decreased. So those are reasons, all of those reasons are useful in deciding to use ligamentous articular strain and give you an endpoint as to when you're done. So tight muscles, fascia, local circulation, neurovascular relationships, muscle joint movement. Those are the big reasons that we're going to choose to use that. So what we're going to do now is we're going to go into the lab and we're going to talk about two easy techniques, and you can certainly be happy to show you more when we get into the question. But in this case, we're going to do an anterior-posterior longitudinal release of the spine, and we're going to go ahead and do a release of the talus. I will leave these up for a moment, but I'll talk you through these rather than just reading them, and we will go from there. So talus release, and of course reassessing when we're done, and then I will ask. I'll be available for questions in a minute or two. So here we are in the lab portion. I'd like to thank Mr. Patel for assisting in this lab session. We're going to go through 3 or 4 techniques, depending on the amount of time that we have, but it'll be the application of ligamentous articular strain with a little bit of a twist. The great thing about some of the principles that we've talked about and will demonstrate is that you can kind of change them to suit not only your needs, but also the needs of the patient. So let's start with treating the spine. Ligamentous articular strain technique, again, is mostly about applying a strain across a ligamentous complex, understanding that the muscular complex will play a role, but in this case, we're really looking for that ligament resistance. So I'm going to go ahead and show what I'm going to do in the prone position, and then I will describe it in the typical position that I use in a patient. So if you wouldn't mind laying on your belly, go ahead and put your face in the hole so you can at least get some air while we do this. I'm going to focus on the spinous processes of the spine, and you're going to find that we're going to take and diagnose a ligamentous disruption. In this case, not a disruption, but a somatic dysfunction. And one of the easiest ways to do that is to go ahead and just take the ligamentous complex and go ahead and push anteriorly. Now, what you're going to do is, instead of gauging in the XYZ axis as you normally would, you're actually going to translate these vertebrae. And so you're actually looking and working in the fourth dimension. 3 dimensions of flexion, extension, rotation, and side bending are the typical ones that we're familiar with. But we're actually going to go ahead and push so that we actually try to translate, much like you would test the OA, these vertebrae. What does that actually allow us to do? Well, it allows us to put pressure on the anterior and posterior longitudinal ligaments. And what's that's going to do? Well, as we mentioned about Fryette's third law, anytime you disrupt one plane of motion or you increase range of motion into one plane, you make those other planes of motion or those ranges of motion smaller. So I'm going to go ahead and again, normally I would do this in the supine position, but just to show you what I'm doing, I'm going to go ahead and cross my fingers over the spinous processes, and I'm going to apply a direct pressure anteriorly. It's firm. It's not a soft one. I'm actually engaging with a firm amount of pressure. And what I've done is picked up a large ligament complex of vertebra, and I'm looking for where do I feel the most resistance as I'm pushing anteriorly. Now he's getting little fasciculations as he automatically starts to respond to what I'm doing. There theoretically shouldn't be a whole lot of motion available when we translate, but what we find is as you maintain that pressure, you're looking for that anterior longitudinal complex to begin to soften. So then what I start to do is I notice that my upper fingers start to soften. And I will shift the pressure to my fingertips, or to the fingers, depending on how you've got them positioned, to the spinous processes that are still remaining hard and firm. I maintain that pressure. It's enough to blanch my fingers, not cause ischemia, mind you, but certainly enough to cause a little bit of discomfort, again, for him, not pain, but I'm pushing very firmly here. As I get softening, I then transition to areas on my fingers where it's not soft. And so I will go ahead and continue that pressure and move it more and manage it more to the places that are starting to resist. As I start to get softening across the complex, I'm beginning to notice that I can feel his breathing to a much greater degree. I haven't started to really feel a huge shift in his CRI or in the softening of the bone as a global sort of complex, but I maintain that pressure. Now what I'm getting is a release. And I'm starting to notice that flexion, despite the compression I have on board, is coming now. As a reminder, flexion in the spine is going to show that the spinous processes come superiorly, and when the body goes into extension, the spinous processes are going to move inferiorly. So now with his breathing, I'm getting flexion and extension, and I'm getting a global softening of the bone. Now, as I mentioned before, we're not actually getting bone softening, but that is the sensory experience that I'm feeling. And I will go ahead and keep transitioning and putting more pressure on those areas that are failing to release and failing to soften until I feel like the whole area really improves. If I could have you flip over onto your back. Now, I generally don't do it in that direction because I feel like I have to apply more pressure. When I have a patient in this position, I'll go ahead and cross my fingers over those spinous processes and then just lift the patient. And you can kind of see the little bit of motion that don't help me now. That's motion I'm applying. So I go ahead and lift up just a little bit. So his weight on my fingers is applying enough pressure to get the same amount of pressure that I was trying to induce, that firm pressure from above, but I don't have to lean quite so hard. I just barely pick up a little bit, apply pressure right on those spinous processes. And except for that one right there, that spinous process that I've got my fingers on, everything else is moving much better than when I started. So again, I do the exact same thing. I lift up, I maintain pressure, I listen to him breathe, and I wait for a general softening. Now, if you want to sort of go from baby food to steak, as you are looking for softening, you are also balancing in the directions of flexion and extension, side bending and rotation. When you apply that pressure, if there is a tendency for the vertebra to want to move in a certain direction, I will apply both a direct pressure and also choose an indirect or a direct counterbalance. What do I mean by that? So in this case, I have a pressure directly. I'm taking it the way it doesn't want to go. But as the vertebra then begin to settle out into a certain position of dysfunction, I can either choose to follow that. So if it wants to side bend right and rotate left, I'll go ahead and take it that way while I'm maintaining this compressive force. If I want to go more direct instead, if it wants to rotate to the right, I'll go ahead and pull against it and then stack it. I'll go ahead and put on pressure, turn it to a side bending that's opposite of what it wants to do, rotate it in the opposite direction that I want to go, and I just keep stacking these positions until everything just binds up and freezes. And then I hold that position until you get that nice muscle spindle, Golgi tendon, mechanoreceptor give way. You get a relief reflex, things all soften and release, and that facilitated segment then eases up and releases. So that's the typical way that I will do it. And again, whether you stack indirectly or directly, thankfully, it doesn't seem to make a huge difference either way. I'm going to go ahead and have you sit up, and we're going to show you how to do an ankle. I'm going to grab a chair here. So let's go ahead and apply it to an orthopedic perspective. We'll give you a couple of orthopedic cases. In this case, we have somebody who comes in with an ankle dysfunction, and they're having pain, and you take them through a normal range of motion, and they seem to be okay. From a diagnostic perspective, I'm going to give you something that's a little bit different than you may be used to. The analogy that I'll use is leaning on a 60-foot boat that's sitting by the dock in the water. You can move that boat two ways. You can take off at a full shot, run into the boat, and you'll probably just bang off it, not get a whole lot of movement out of the boat. Or you can walk up to the boat, lean on the boat, and wait, and the boat will start to drift as you overcome the moment of inertia, and it'll begin to move. I'm going to do that with the joint complex. I did that with his spine, and now I'm going to do it with his talus. So in this case, I go ahead and grasp his calcaneus with my bottom hand and take a hold of his talus. And now I'm going to go ahead and lean on the talus from an anterior to a posterior motion. As I lean on that talus, at first you'll get resistance. It's normal to feel that hard resistance. The joint's not going to move that much. But as you maintain that pressure, it should start to soften and drift and move, in this case, posteriorly. It moves pretty darn well. I go ahead and grasp his calcaneus and then reach a little bit further laterally around his talus and then pull anteriorly. Okay? So in this case, I've grasped the calcaneus. Now I'm going to pull the talus anteriorly, and I'll go ahead and do that. And I don't really see that it moves anteriorly nearly as well as it moves posteriorly. So in this case, he has a posterior talus. Remember, we label it for what it can do. Okay, so I'm going to apply ligamentous articular strain. I'm going to go ahead and grasp the calcaneus firmly, and then I'm going to pull the talus anteriorly. Okay, it's stuck. I'm then going to go ahead and cheat a little bit and throw in another compressive force that we talked about. So I'm just going to use something. In this case, I'm going to use my knee. I'm going to drive a little bit of a compressive force along the long axis of the first metatarsal into that tarsal complex. So I go ahead and pull the tarsal anteriorly. I'll reposition my knee, and then I'll pull and compress, and then I'll just wait. And I'm waiting for the general first softening of that talus bone to come anteriorly. I'm going ahead and I'm sort of adjusting rotation and side bending to see if I can feel like it's more resistant or more ease in one direction or another. In this case, I tend to move in the more of the resistance, and I'll just hold that pressure until I start to feel that talus start to release. And as that talus starts to shift and slide, I just follow it. Now remember, as you apply that initial pressure, you're not going to feel it release. It's going to take 5, 6, 7 seconds before, as you're doing a range of motion, before it starts to move. The same thing is going to be true when you put this technique on. I pull it posteriorly and I add the compression. It may be 10 seconds, 20 seconds, it might be 30 seconds before you start to feel it give way and start to soften. And so now we're just starting to get some good softening and release of that talus anteriorly. I'm going ahead and just sort of rotating and side bending to see if I notice any changes. I'm using the bottom part of my hand to also check how that navicular, that first cuneiform, and how the tarsal complex is doing as that talus is sliding forward. So while I'm focusing on moving the talus anteriorly, I'm also looking at the rest of the tarsal complex to get a feel, has the whole agonist, antagonist, synergistic complex, ligamentous complex, begun to break free and move. So then, after I feel like it's moved, I'll go ahead and back and test it, and it moves posteriorly very well. It moves anteriorly very well. Remember, anytime you check the talus, it's really good form to go ahead and grab the tibia, and then go ahead and, I'm sorry? 5 minutes. You go ahead and instead of just checking the talus on the calcaneus, you're also going to check the talus under the tibia. So you grab a hold of the tibia and you pull the talus anteriorly, and it gently stops and then it slides anteriorly, and that's pretty good. And then I'll go ahead and firmly grab the tibia and apply a posterior push on the talus. And under the tibia, it moves posteriorly. So I've got pretty good motion at the tibio-talar joint and now the talocalcaneal joint. And again, I had a small release down here at the navicular complex. So joints in the extremities can be done very easily. I've got a few minutes left here, so I'm going to show you one of my favorite ones. And people who have wrist dysfunction, oftentimes you'll go ahead and you'll do that carpal complex and you'll get your snapping and your popping. But there'll be one spot that just doesn't want to move. Now for him, it's right under that finger right there, so I would say his lunate isn't moving quite the way I would like to. And it really doesn't want to, it grinds a little bit. So I'm just going to go ahead and compress with my thumbs, and I'm going to go ahead and open up his carpal complex. So remember, we've got an arch. So with my hands underneath, I'm spreading the carpal complex, and I'm compressing onto the lunate bone. So I open my hands, I compress with my thumb on that bone that doesn't want to move, and I hold it. And I just wait till it starts to soften and release and relax, and I'll chase. If it starts to give way, I'll chase where the firmness is, so I'll kind of move with a little bit of side bending, a little bit of rotation, and then I'll wait for that release. Now, and I haven't even got to the best part yet. One of the things that you typically will have is that when you open up someone's wrist carpal complex and they feel better, it tends to come back. If you'll want to go ahead and check their interosseous, meaning the joint between the proximal metacarpals, oftentimes one of those articulations will have become really locked up, and it will continue to maintain the return of this somatic dysfunction. So what I then go ahead and do is I do the same thing. I look at the arch that's there, the arch of the metacarpals, along with the arch of the carpals. I'll get on, in this case, the second and third proximal metacarpal. I'll spread his arch with my fingers, and then I'll compress the two proximal metacarpals right into each other. And I get nothing but just a locked sensation. And I'll hold that. Now I'm compressing my thumbs towards each other and these two metacarpals right into each other. So I'm actually increasing that compression that is being maintained. And what happens is that as I start to get that softening, the bones will start to feel like they start to begin to slide past each other. Now clearly it's not nearly as much as it appears in my hands, but that softening is what allows this carpal complex, which of course is anchored to the base of the metacarpals, to have a much more persistent fix on that joint. We'll go ahead and do a shoulder. As a reminder for motion of the articular complex within the shoulder, as the clavicle and scapula come down laterally, the humerus tends to come up and externally rotate. So there's this sort of piston-like motion that's consistent with the Traub-Herring wave, but also from the ligamentous complex. I can then go ahead and take the patient who has dysfunction, and since I know that the clavicle drops down and kind of externally rotates and the scapula comes towards me, I can go ahead and push from a superior to inferior and bring it laterally, and then take the humeral head and move it up superiorly and externally rotate it, and I'll push and hold, and I'll see if any of that doesn't really move the way it wants to. Again, leaning on that boat, waiting for it to move. In this case, his scapula does not want to externally rotate towards me. So I'll maintain that pressure in this sort of strained pattern until I feel his scapula start to soften and relax. And it may do it all at once, or it may do it in stages. And I'll just keep following it until I feel like there's general softening. And then I'll go ahead and do it in the opposite direction. So with a flexion type or an external rotation, we get the clavicle and scapula dropping laterally and opening up a bit as the humerus comes up and externally rotates. In extension, or in an internal rotated state, the clavicle and scapula come up and in, and then the humerus drops down and internally rotates. So there's this motion in internal rotation, and this motion in external rotation, and then internal motion. So I'm going to go ahead, and since I've done one aspect of that, I'm going to go ahead and pull the humerus down and internally rotate it as I pull up on the clavicle and scapula, and see if I get any binding at the AC joint, see if I get any binding with the humerus and the glenoid. And in this case, the clavicle does not want to come superiorly particularly well. and I just hold it until it starts to soften and relax. And then as it releases, the humerus drops down inferiorly and internally rotates. Clavicle and scapula come up. And as I get softening, I'll then go ahead and repeat external rotation to make sure that I haven't locked it up into internal rotation. And I got softening in both directions. And I've got a diffuse shotgun sort of technique for the shoulder using ligamentous articular strain. We're now going to go ahead and turn the time over to you all. And if you have any questions, I'd be happy to answer them as best I can. And it was good speaking with you. And hopefully, if you have any questions, you'll feel free to shoot me an email, and I'll answer what questions I can. So thanks, and be well.